So good evening, ma'am. Shall we start, ma'am? Yes,
Sure.
ma'am.
Vani?
Yeah, we'll start. Yeah.
So good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. I would like to welcome all the delegates and I request them to post their comments in the comment box so that we can have a short Q&A session at the end of the presentation. So now it's time to introduce our convener for today's program. Um, so I'd like to take my pleasure to invite our convener, Dr. Vani, ma'am. Vani ma'am has completed her PG from Andhra Medical College, Visakhapatnam, and presently working as a professor of OG Department, Government Medical College, Srikakulam. Madam has published 42 publications and in international journals, and Madam is a speaker in many national conferences. Madam has her fellowship in advanced courses in medical education and ICMR fellowship in biomedical research. So, with this introduction, I welcome you, ma'am. Ma'am, before going to the session, we would like to play our Shield Connect web page. So I request your permission to play a 1 minute video, ma'am.
Proceed.
Dr. Stalin, there's no audio.
Uh,
Yeah, ma'am. There is some technical issues, I guess, ma'am. Audio is not playing. So Shield Connect is a new initiative of our Shield Healthcare, ma'am, and it's a digital platform with all updated informations from menarche to menopause. And you can see blogs related to our women's health, ma'am. And all our webinars are connected through our Shield Connect web page. And you can see the details of the upcoming webinars, the details of the past webinars which has been done by our company in this web page, ma'am. We have a separate page for PCOS awareness. So in this page, you can see the opinions or information of the doctors made in various regional language. You can see a short video of the PCOS, and we have our leaders page here, ma'am. So we have more than 200 leaders, and we have a separate for our speakers, ma'am, the doctors. So if you are interested in giving any blogs, so then we will be happy to post in our web page, ma'am. So these are yes, ma'am. This is your profile. That each doctors have their own profile, and what are the webinars had been done by the particular doctor be available in our web page, ma'am. So I request you to give some of the blogs or any informations which we can post in our web page, ma'am. Then we also have a separate page for your our key opinion leaders. This is for Dr. Rekha, ma'am, and our leaders. We have more than 220 leaders that is supporting our company, and and you can find the details of all those doctors who are associated with our company, ma'am. So I request the participants to go through our webpage and be updated. Thank you, ma'am. Ma'am, now you can start your.
Thank you, Stalin. Yeah, yeah. Thank you, Stalin. And welcome all the audience who are attending the webinar, who are logged into the webinar. So today we thought we'll be dealing with two important contemporary topics. See, the first topic is on the new FIGO classification regarding the adherent placenta. So this topic will be dealt by Dr. Dr. Sailaja Pinjala, a very close friend of mine. She is associate professor at Andhra Medical College, Visakhapatnam, and a good academician. So why we thought this topic is very relevant here is that the classification is quite new. The classification is more appropriate for clinical application in regular practice. So that is why this topic is selected. Dr. Sailaja Pinjala, incidentally, she is the secretary of Obstetric and Gynecological Society of Visakhapatnam. She is organizing joint secretary of the forthcoming UFOXY of South Zone, which we are holding it on March 20th and 21st of 2021. She is also the fellow of ICOG. She presented number of papers in state and also national level conferences. For her credit, she has 10 publications in indexed journals of good reputation. Number of times she had been examiner for UG and PG examinations in South India. She is faculty in a number of state and national conferences and plenty of webinars also in the last year, with a special interest in practical obstetrics and high-risk pregnancies management. So over to you, Sailaja. We would like to hear from you in the next 20 minutes. What is this new FIGO classification regarding adherent placenta and how it can be clinically applied in our regular practice?
Thank you, Dr.
Dr.
Vani.
Sailaja.
Thank you, Dr. Vani, for your nice words. First of all, I would like to thank, good evening, everyone. First of all, I would like to thank Shield Healthcare for giving me this opportunity. Shall I share my screen?
Yes, ma'am. You can share, ma'am.
Is my screen visible now?
Yes, ma'am. You can maximize, ma'am.
In the next 15 minutes, I'll be talking on placenta accreta spectrum and the new FIGO classification and its significance. So just before going to the classification, I would like to take you all through the quickly through the historical aspects of placenta accreta. The placenta, Irving and Hertig were the first persons to publish a cohort study of placenta accreta in the national literature in 1937. In their study, it was actually a comprehensive study of clinical and histopathological description of 20 cases, along with a literature review of 86 cases that were published before 1935. In all these studies, they mentioned as the name of adherent placenta for a placenta accreta, and the clinical description which they gave was the placenta adherent to the uterine wall without easy separation or a bleeding from the placental bed. And the histological picture which they produced was the absence of decidual layer or the Nitterbugs layer. In their study of 20 cases, there was only one case of a previous cesarean delivery. So later in 1966, Luke et al. Redefined placenta accreta as the spectrum of abnormal placentation disorder. And he was the first person to describe the three forms of adherent placenta histologically. So according to them, the placenta accreta is a direct attachment of placental trophoblast to the uterine myometrium, or with no normal intervening decidua or the basalis layer. And placenta increta is the partial invasion of the trophoblast through the uterine myometrium, and placenta percreta is a complete invasion of the trophoblast through the uterine myometrium. And they also described as the placenta accreta total, that means when the entire placenta is involved, partial when only a cotyledon is involved, and focal when a small area in the cotyledon is involved. After 1966, number of studies were published in the literature, but all these studies, they use different terminology like placental adhesive disorders, abnormal placental adherence, advanced invasive placentation, abnormal myometrial invasion. And not only that, there was a wide variation in the reported prevalence in all these studies. The clinical description which was given by the authors of all these studies also varied very much. Like some presented as a difficult removal of manual removal of placenta, a piecemeal removal of placenta, absence of spontaneous placental separation within 30 minutes, even after the active management of the third stage, or retained placental fragments requiring curettage, or heavy bleeding from the placental site after removal of the placenta during the cesarean section. So all this actually created a lot of confusion, but so few information could be gathered from the literature, like its association of accreta with placenta previa, and it was also evident that there is a linear rise in the accreta incidence all over these 5 decades. And this rise in the incidence paralleled the incidence of the cesarean section deliveries. But no attempt was made to differentiate the various forms of invasive placenta, and no attempt was made to differentiate the non-accreta placental retention from the accreta. So labeling non-accreta placental retention as accreta or morbidly adherent placenta actually led to an overdiagnosis, and this also influenced the treatment decisions, leading to overtreatment. So, the as far as the data that is available so far cannot be used for the clinical research or to compare the studies for evaluating the management strategies, because they lacked a uniformity in the diagnostic criteria. So, so it is very important to have a universally accepted diagnostic criteria, not only to evaluate the demographic factors, but also to understand the various risk factors, and also to improve the understanding of the underlying pathology, and for the development of appropriate management strategies. So in 2018, FIGO developed the classification of placenta accreta spectrum disorder under the chairmanship of Professor E. Janov. So the FIGO classification, they classified the placenta accreta as grade 1, 2, and 3. So grade 1 is abnormally adherent placenta or the placenta accreta, and the clinical criteria given for the diagnosis of grade 1 accreta is at vaginal delivery is there should be no separation of the placenta with the synthetic oxytocin and gentle controlled contraction. And when an attempt is made to remove the placenta manually, this should result in heavy bleeding from the placental implantation site, requiring mechanical or a surgical procedure. And the clinical criteria that is given for the diagnosis of grade 1 during laparotomy, that is during a C-section, the same thing like non-separation of the placenta with synthetic oxytocin, and gentle or with the gentle controlled contraction. Macroscopically, the uterus had to be nearly normal, like there should not be any obvious distension of the placental bed, or any placental bulges should not be present, and there should not be any placental tissue seen invading through the surface of the uterus, and there should not be any abnormal neol. So at least a minimum neovasculature can be present. The histological criteria that is given for the diagnosis of grade 1 placenta accreta is the microscopic examination of the placental bed samples that is obtained from the hysterectomy specimens should show extended areas of absent decidua between the villus tissue and the myometrium, with the placental villi attached directly to the superficial myometrium. And the diagnosis cannot be made just based on the examination of the placenta that is delivered, or the biopsies randomly obtained from the placental bed. So this is the histopathological slide of a normal placenta, where you can see the normal placental villi that is separated from the myometrium by the decidua. So this is the slide of the placenta accreta grade 1, where you can see the villi, the placental villi, direct contact with the myometrium without and the absence of the decidua in between. The grade 3 is abnormally invasive placenta or increta, and the clinical criteria given for the diagnosis of grade 2 at laparotomy is there should be some abnormal macroscopic findings over the placental bed, or that is on the uterus where the placenta is actually attached. So they can be a bluish or purplish discoloration or the distension of the placental bed. It is seen in the form of placental bulges, or a significant amount of hypervascularity. That is, multiple vessels can be seen running parallel craniocaudally in the uterine serosa, and there should be no placental tissue seen invading through the uterine serosa. And on gentle contraction, there should be an indrawing of the uterus without separation of the placenta, and this is known as a dimple sign. So these are all the clinical criteria for grade 2. So here is a picture of a grade 2 placenta accreta, where you can appreciate the discoloration as well as the bulging and the neovascularity. And histological criteria for the diagnosis of grade 2 is the hysterectomy specimen or the partial myometrial resection of the increta area should show placental villi within the myometrial fibers, and sometimes this can also be seen in the lumen of the deep uterine vasculature. So here it is, this is the histopathological picture of the placenta accreta grade 2, where you can see the placental villi invading into the myometrium, and here you can see this within the vessels of within the myometrium. And grade 3 is again classified into A, B, and C. A is, the invasion is limited to the uterine serosa, and the clinical criteria that is given for the diagnosis of grade 3A is at laparotomy. Along with the macroscopic findings that are seen in grade 2, they should be, placental tissue should be seen invading through the surface of the uterus. but there should not be any invasion in the adjacent organs. Even the posterior wall of the bladder should not be involved, and there should be a clear plane of cleavage between the bladder and the uterus. This is a picture of grade 2, grade 3A, where you can see the bulging, the prominent veins and the discoloration, and here the bladder, which is seen separate from the uterus. And the histological criteria that is given for the diagnosis of 3A is the hysterectomy specimen should show villous tissue within, or there should be a breach in the uterine serosa. So here is the histological picture of the grade 3A, where you can see the placental villi with a breach in the serosa of the uterus. And grade 3B is where the urinary bladder is invaded. The clinical criteria here is the placental villi should be seen not only invading the bladder, but no other organs. And there should not be any surgical cleavage between the bladder and the uterus. And histological criteria, not only the breach in the uterine serosa, there should be invasion of the bladder wall tissue and the or the urothelium. Grade C is the present, that is grade 3C is invasion of the adjacent pelvic organs or the tissues. The criteria, clinical criteria given is there should be invasion of placental villi, not only invading the, there should be invasion in the either in the broad ligament or vaginal wall or in the pelvic side walls or any other pelvic organs, with or without invasion of the bladder. Even the histological picture has to be seen in the same pattern. So let's see what are the markers of prenatal diagnosis of placenta accreta spectrum. So ultrasound is supposed to be the best modality for the diagnosis of the placenta accreta spectrum. The markers can be used for the diagnosis of this one during the second or in the third trimester, and all the findings may not be need not be present for a diagnosis. The overall performance of ultrasound is very excellent, with sensitivity of 90% and specificity of 96%, and the sensitivity can be increased by combining the grayscale with the color Doppler imaging, so that the negative predictive value can increase up to 98%. So European working group of abnormally invasive placenta have given certain markers and described them for the diagnosis of placenta accreta spectrum. So what are these markers? Abnormal placental lacunae. So these are the large multiple irregular intraplacental sonolucent spaces which are seen in the center of the lobule or in the cotyledon adjacent to the involved myometrium, and this gives a moth-eaten appearance of the placenta. So presence of a moth-eaten appearance of a placenta is diagnostic of placenta accreta because it has a very low false positive rate, and when a Doppler is added, it produces a turbulence in the blood flow. And it has to be differentiated from the normal vascular lakes and also from the Swiss cheese pattern that is seen in the partial mole. The next marker is the loss of clear zone. So what is a clear zone? It is the hypoechoic plane or a zone that is seen in between under the placenta, separating the placenta from the underlying myometrium. But this is normally obscured or cannot be visualized when the placenta is situated posteriorly or in the with the advancing gestational age, or when the bladder is over distended, and by the direct pressure or by the probe also the zone cannot be visualized. So this is the loss of the clear zone is a marker of the placenta accreta, and the strength of this marker lies in its negative predictive value. That means when you are able to visualize the clear zone, you can 100% be sure that there is no placenta accreta. Next marker is a disruption of the bladder line. So what is this bladder line? It is a hyperechoic white line that is seen in between the bladder wall and the uterine serosa. So this is a normal bladder line, and any disruption in the bladder line, either interruption in the continuity of the bladder line or the thickening of the bladder line or the irregularity of the bladder line that is seen is a marker of a placenta accreta, percreta actually. And when the Doppler is switched on, you can see the increased vascularity in this particular area, and this has a high specificity of 100%. So when this is present, it is definitely placenta percreta. Next marker is the myometrial thinning. So what is a normal thickness of the myometrium in the lower uterine segment? It is around 2.4 millimeters at a near term or in the third trimester. So when there is thinning of the myometrium or absent myometrium or less than 1 millimeter, it is considered as that placenta invasion is into the is of the invasive type, that is the increta. The other markers are the placental bulge and the focal exophytic mass. The color Doppler markers are the increased vascularity or the hypervascularity between the uterus and the bladder, and subplacental hypervascularity, presence of a bridging vessels that is extending from the placenta across the myometrium beyond the serosa onto the into the bladder. This is very important in the diagnosis of placenta accreta. And also the presence of the feeder vessel, the turbulence, the high velocity blood vessels in the placental lacunae is also an important, that creates actually causes the turbulence upon entry of the blood into the lacunae. So these are the pictures of the color Doppler, where you can see the subplacental hypervascularity, and here this is the bladder and the uterus. Here at this junction you can see the uterovesical hypervascularity. So what is the role of MRI in the diagnosis of PAS disorders? This is very important in 3 clinical scenarios, like when the placenta is situated posteriorly, where you cannot use the bladder as a window, and for the assessment of the depth of myometrium and the parametrium that is involved when there is an invasion, and for the evaluation of the myometrium and the placenta in the lateral portions of the uterus. So what are the MRI findings which are in favor of placenta accreta are the uterine bulging into the bladder, interruption of the bladder wall, loss of erythroplacental intense line in the T2 weighted images, abnormal vascularization of the placental bed, dark intraplacental bands which are seen in the T2 weighted images, and myometrial thinning and focal exophytic masses. The sensitivity of MRI is around 75 to 100, and specificity 65 to 100%. So these are the images. This is a normal placenta, which you can see the normal homogeneity of the placenta without any bulging, and there is a well delineated biometrial wall also can be seen. So this is a picture of an MRI where you can see the placental bulging into the bladder, and there is also a loss of continuity in the myometrial wall, and you can appreciate the dark bands also here. This is a T2 weighted image of MRI. So so are there any markers for screening of placenta accreta spectrum in the first trimester? Yes, in recent studies have shown that the cesarean scar pregnancy is a precursor of the one of the different grades of placenta accreta spectrum disorder. So what are the what are the criteria for diagnosis of the cesarean scar pregnancy in a transvaginal sonogram? It is identifying the gestational sac anteriorly at the level of the internal os within the visible myometrial defect, and there should be a clear-cut evidence of functioning trophoblast. That is, the placental circulation has to be visualized on the color Doppler, with the vessels with showing a high velocity, peak velocity of more than 20 centimeters per second, and a low impedance of or the pulsatility index less than 1, and it can be differentiated by from a spontaneous abortion by the absence of or the negative sliding organ sign. So what is this negative organ sliding sign is when a gentle pressure is applied with a transvaginal probe, the gestational sac will be displaced if it is a spontaneous abortion, and this displacement is not seen when if it is a cesarean scar pregnancy. So what FIGO recommends for the prenatal diagnosis and screening of placenta accreta spectrum are the ultrasound is should be the first line for the diagnosis of placenta accreta disorders, and when a cesarean scar pregnancy is identified in the first trimester, the women should be counseled regarding the high risk for requiring a hysterectomy, and whenever the women come for an anomaly scan in the second trimester, every woman should be asked if they had a previous cesarean delivery, and if it is so, a prompt careful assessment of the placental implantation site has to be done. And all these signs which are observed has to be prescribed or described in the standardized protocol that is given, and MRI is not essential for making the prenatal diagnosis of the suspected the placenta accreta spectrum, but it is useful for evaluating the pelvic extension of the placenta percreta. So FIGO also has given some standardized database for reporting cases or reporting studies, cases for future clinical research. This is the database that is given by FIGO. So the studies which we want to present or publish should be in this format. To summarize, placenta accreta spectrum has an impact on the maternal health globally, and its prevalence is likely to increase in near future with the increasing C-section rate, and maternal outcome depends on the identification of the condition before or during delivery, and also differentiating adherent from the invasive forms of placenta accreta. And accurate estimation of its prevalence and outcome currently is problematic because of the lack of the universally accepted clinical criteria and lack of detailed pathological examination in most of the series. So it is very important to adhere to this FIGO classification so that this is to improve the future systematic reviews and meta-analysis, and to provide more accurate epidemiological data for development of new management strategies. Thank you very much for your patient hearing.
Thank you very much, Shailaja. So that was very elaborate lecture on the new FIGO system of classification. It is for the obstetricians to follow this. So because FIGO wants to do certain meta-analysis of the placenta accreta spectrum disorders. So therefore, all obstetrician has to adhere to the rules and classify in the same format like what was told. And then you have clearly told about the clinical findings on laparotomy, histological findings, and how on imaging. So these can be identified at the best. And another important point for everyone to note is the mid-trimester is the ideal time for diagnosing placenta accreta spectrum disorders. And MRI is not very specific or sensitive, should be reserved only to cases where the placenta is posterior or lateral, where imaging through ultrasound is not feasible. Otherwise, ultrasound is a gold standard one. So thank you very much, Shailaja. And then I'll invite the second speaker, Dr. Rekha Dadich, another close friend of mine. She's also actively involved in the organizing committee of the forthcoming South Zone UFOXY to be held at Visakhapatnam, March 20 and 21st. She's a consultant obstetrician and gynecologist at Seven Hills Hospital, Visakhapatnam. She has good academic reputation and she's a good practitioner known to all citizens of Visakhapatnam. Over to you, Dr. Rekha Dadich, would be speaking on another important contemporary topic, prediction and prevention of preeclampsia. We all know that preeclampsia is an important contributor to maternal mortality and maternal near miss cases. So how to predict and how to prevent preeclampsia? Over to you, Dr. Rekha.
Thank you, Dr. Vani, for your nice words. And a very good evening to all of you. At the outset, I would like to thank Shield Healthcare for giving me this opportunity today, and Dr. Vani again for involving me in this talk. I should start sharing my screen. Just 1 minute. So my topic today is prediction and prevention of preeclampsia. United Nations Sustainable Development Goals 3.1 aim at reducing global maternal mortality rate to less than 70 per 100,000 births by the year 2030. And this burden of maternal mortality is disproportionately higher in the less developed countries, especially sub-Saharan Africa and Southern Asia. Hypertensive disease in pregnancy is a leading global cause of maternal death and disability. The incidence globally stands at 2 to 8%. India's is 8 to 10%, and globally around 50,000 deaths are attributed to hypertensive diseases in pregnancy. Women who develop hypertensive disorders in pregnancy are at a higher risk of developing chronic hypertension and 2 times the higher risk of developing myocardial ischemia and stroke later on in their life. Definition of mild and severe preeclampsia, as we all know, any new onset systolic blood pressure of more than or 140 millimeters or a diastolic of 90 or more on at least 2 occasions, at least 4 hours apart after 20 weeks gestation in a previously normotensive woman, along with proteinuria of more than 300 milligrams or a protein creatinine ratio of more than 0.3 or at least a urinary district reading of +1 or more. When the blood pressure systolic goes above 160 and the diastolic blood pressure is around 110 or more, which is confirmed again within a short span of time, we label this case as a severe preeclampsia. And if there is a multi-system involvement, it will be evident in the form of thrombocytopenia, impaired liver function, impaired renal function, unexplained persistent right upper quadrant pain, pulmonary edema, convulsions, visual disturbances, and eventually may lead to death. Another way of categorizing preeclampsia is an early onset preeclampsia, the one which manifests before 34 weeks of gestation. This has shown to have more fetal-maternal complications, and the pathogenesis here is an impaired placental formation. Hence, it is also called a placental preeclampsia. The other one is late onset preeclampsia, which manifests after 34 weeks of pregnancy, has lesser fetal-maternal complications as opposed to early onset preeclampsia. And this is more because of the maternal predispositions to vascular endothelial dysfunctions due to pre-existing conditions like, say, diabetes or obesity or hypertension or macrosomic fetus or multiple pregnancies. Hence, the extensive research in the last few decades has focused on prediction of pregnancies which are at a risk of developing preeclampsia later on. And this prediction is critical in order to undertake pharmacological interventions to either prevent the development of the disease or to improve outcomes among those who develop preeclampsia by diagnosing it at an early stage and by intensive monitorings. This slide basically tells the basic pathogenesis of preeclampsia, wherein an abnormal placentation or pre-existing maternal factors, immunological factors, or even genetic factors, they all lead to basically a uteroplacental mismatch, which leads to a lot of cytokine activation, inflammatory responses, immune activations, and all of that ultimately leads to a endothelial cell activation locally or a generalized endothelial activation, wherein all the systems are involved and the mother manifests severe forms of preeclampsia leading to complications and death. Now, this table I have taken from Foxy's good clinical practice recommendations for hypertensive disorders in pregnancy. And as you all know, history has always been a very important aspect of reaching to a diagnosis. And they say, well, history well taken is half the diagnosis reached. And in case of preeclampsia, there are a lot of risk factors, which if we evaluate with a fine comb, we can get a lot of information from the patient, and that can be utilized to form a kind of high risk score, which this table very clearly says. All factors have been enumerated. Factors have been given a score of 1, 2, or 3. And at least a score of 3 or more is required to label a person as having a risk of developing preeclampsia later on in her pregnancy. Most of these factors can be elucidated at the initial antenatal visit, and a rough idea of her risk factors risk score can be calculated. Now, having said that, historical risk factors predict approximately only 30% of women who are at risk. And use of these risk factors along with laboratory investigations and imaging tests to calculate an even more accurate risk is an ongoing area of investigation. Now, what are the properties of an ideal marker? It should be one of the key players in the pathogenesis. It should appear earlier than the clinical manifestations of the disease. It should have a good specificity and sensitivity. It should be very specific for the disease, should be cost effective, widely available, and easily done as an investigation. And it should either not be detected in normal pregnancies, or its values for normal pregnancies at any gestation should be known. So what are the biophysical markers? We all know blood pressure measurement is one of the very important part of a clinical examination of a patient, a pregnant patient, and it remains the cornerstone of early diagnosis of blood pressure, of preeclampsia, sorry. And so what kind of instrument? Mercury sphygmomanometer still holds true. It's the gold standard. Aneroid apparatus are also good, but digital machines need frequent calibrations, and for that reason, they are not as accurate as a age-old mercury sphygmomanometer. Traditionally, 4 readings should be taken, 2 in each arm, and calculate the mean of the 4 readings, and that forms a basal blood pressure recording of the pregnant woman. Now, this examination comes with its own limitations of interpersonal variations and errors associated with the apparatus, as I already said, lack of calibration, etc. Maternal posture is very important. The patient should be sitting without crossing her legs, without clenching her arms. Her back should be straight and relaxed. The equipment, the apparatus should be at the level of her heart, and then the pressure has to be recorded. Taking into consideration all these things, mean arterial pressure emerged as a better predictor of preeclampsia than systolic and diastolic measurements alone. And moreover, mean arterial pressure is a better indicator of tissue perfusion than the systolic pressure recordings alone. Mean arterial pressure, we all know the formula. It is diastolic pressure plus 1/3 of systolic minus diastolic, or diastolic pressure plus 1/3 of pulse pressure. It should be measured using an automated validated machine into which the mean arterial pressure reading comes off by inherent calculations. It is to be measured at around 11 to 13 weeks once, and then again around 20 to 24 weeks. Now, mean arterial pressure is also affected by several maternal characteristics and her medical history, like it decreases with gestational age and height and increases with the increasing weight of the pregnant woman. It is higher in women with chronic hypertension and in those with personal or family history of preeclampsia. It is lower in smokers and in Paris women who have no previous history of preeclampsia. Thus, mean arterial pressure has to be adjusted against all these variables, and thus it is being expressed as multiples of the median. In pregnancies that develop preeclampsia, mean arterial pressure MOM at 11 to 13 and 20 to 24 weeks gestations is higher as opposed to normal pregnancies at the same gestational age. And this increase in mean arterial pressure is inversely related to the gestational age at delivery. The other biophysical parameters is uterine artery Doppler, which has been in use for a very long time, and it was predominantly a second trimester marker. But of late, it has been associated with, calculated along with other parameters, and it is becoming more of a first trimester marker too. Now, the basic science behind it is that impedance to flow of the uterine arteries decreases as pregnancy progresses, and increased impedance at any gestational age constitutes a feature of preeclampsia. Now, this impedance arises due to a defective differentiation of the trophoblast, leading to a defective invasion of the spiral arterioles and a failure to form a low resistance flow. And this kind of an impedance is reflected upstream in the uterine arteries, which is picked up during Doppler studies. So there were two important parameters which were associated with preeclampsia: diastolic notchings and flow waveform ratios. Now, diastolic notching was a very exciting initial finding on Doppler. It could be unilateral or bilateral, but then it was found out that it was commonly seen in 46 to 64% of pregnancies which did not have preeclampsia at any time throughout, and it was seen to persist up to 25 weeks of pregnancy. So many studies have thus evaluated diastolic notching, and they have found that it has a low positive predictive value, but still holds a good negative predictive value of 97%. Thus, as a standalone marker, it has low value. The other Doppler parameter is flow waveform ratios like high resistance index or pulsatility index. These values are expressed as centiles or multiples of median, and anything above the 90th centile for that gestational age is considered as a higher pulsatility index. Now, this pulsatility index is an accurate has accurate predictive value in the first trimester at around 40 to 70% when considered alone. But when you combine a pulsatility index along with other biomarkers and mean arterial pressure, the predictive value goes up to 90%. There has been a study by Presencia et al. In which they have done a sequential Doppler that in the first trimester, and then a sequential follow-up Doppler in the second trimester of the same cases who had a raised PI in the first trimester. And they found out that of those cases who had a persistently raised PI, 94% of these cases developed early preeclampsia, and 75% of these cases developed later preeclampsia, wherein there were 37% of cases who still did not develop any preeclampsia. So uterine artery Doppler is a better detector of early onset preeclampsia. And a landmark study has also found out that when you club it along with an algorithm which incorporates maternal historical risk factors, uterine artery pulsatility index, mean arterial pressure, and biomarkers like pregnancy-associated plasma protein A and placental growth factor, the detection rate goes up to 93% with a false positive rate of just 5%. And another interesting Doppler study was the ophthalmic artery Doppler. So in a meta-analysis by Calafat et al., they found that they did 3 studies which had around 1,119 pregnancies, and they found a first diastolic peak velocity of more than 23.3 centimeter per second, showing a modest sensitivity of 61% and specificity of 73% for prediction of early onset preeclampsia. Now here, trophoblastic invasion, spiral artery invasion has no role. It is just a reflection of the maternal hemodynamic status. Thus, as a standalone test, it has very less clinical significance, but it can be combined with other markers to give a better value. Now, what are the biochemical markers of preeclampsia? There are several biochemical markers which have been studied throughout. Some of them are urinary or maternal serum. Many of them originate from the placenta, and many of the markers are already being utilized for first trimester screening for aneuploidies. I'll go through them one by one and then we'll discuss their values. Now, pregnancy-associated plasma protein A is a glycoprotein derived from placenta, and the levels rise throughout pregnancy. It is already being used in first trimester screening along with serum beta HCG and nuchal thickness. A large population-based trial found pregnancy-associated plasma protein A levels less than 10th percentile were significantly associated with preeclampsia, intrauterine growth retardation, and small for age infants. Alone, it has a 10 to 20% sensitivity, and when combined with Doppler studies, the sensitivity rose to 70%. Another placental factor is placental growth factor. It is a pro-angiogenic factor, and it is said to promote angiogenesis even in the presence of ischemic situations. It is a second trimester marker. In normal pregnancy, placental growth factor levels rise and peak at around 26 to 30 weeks. No rise is indicative of a dysfunctioning placenta. In preeclampsia, the levels of placental growth factor can be abnormally low when compared to normal pregnancies at the same gestational age. A value of less than 100 picogram per ml has been found to be associated with increased maternal and perinatal risk. This placental growth factor has also been studied extensively with another placental anti-angiogenic factor called SFLT1 or soluble FMS-like tyrosine kinase 1, and their ratios are actually these ratios are coming out with different findings, like a ratio of less than 38 rules out onset of preeclampsia within 1 week, independent of any gestational age, and anything more than 85 or more than 110 is indicative of a high risk for development of preeclampsia. Other placental markers like placental protein 13 is secreted by the placental trophoblast cells and is associated with normal placentation. So serum levels of PP13 slowly rise with the gestational age. A concentration was found to be significantly lower in first trimester in patients who developed preterm and early onset preeclampsia. With a cutoff of 0.39 multiples of median, it has a sensitivity of 100% for early onset preeclampsia and 85% for preterm preeclampsia at an 80% specificity. Serum inhibin A is also a sensitive marker for the prediction of preeclampsia. A mid-trimester serum inhibin A concentration of less than 1.5 multiples of median has a sensitivity of 60% and a false positive rate of 16%. Beta HCG has been a first trimester as well as second trimester marker, and it has a sensitivity of 83% with specificity of 95% for the diagnosis of preeclampsia. Now, angiogenic biochemical markers in preeclampsia, this is an upcoming field of investigation, and worldwide there are several ongoing studies to correlate this and find commercially available tests for the same. So basically an impaired trophoblastic invasion and a hypoperfused placenta, it affects the formation of the pro-angiogenic factors and anti-angiogenic factors in the way that there is an increased anti-angiogenic factor production in the impairedly perfused placenta, and that is reflected in the maternal blood. So studying these trends helps us in predicting preeclampsia. The common angiogenic markers are pro-angiogenic markers such as vascular endothelial growth factor, placental growth factor, and anti-angiogenic markers like soluble FMS like tyrosine kinase 1 and soluble endoglin. Of these, SFLT, placental growth factor, and soluble endoglins are of special interest. Now, SFLT is derived by splicing of FLT, which is a receptor of vascular endothelial growth factor and placental growth factor. And SFLT, what it does is it binds to these factors and inactivates them. So actually it stops angiogenesis, and it further helps in creating an ischemic environment. Circulating levels of SFLT and placental growth factor alter several weeks before the actual onset of the clinical disease, and they correlate well with the severity of the disease. SFLT levels normalize within days after delivery, which actually coincides with improvement in proteinuria and hypertension. So it can be said that SFLT reflection in the maternal blood is actually coordinating well with the onset of the disease and then the clearing of the hypertension. Higher SFLT levels have been noted in first versus second pregnancies, twins versus singleton pregnancies, in molar pregnancies, and in pregnancies with fetuses having trisomy 13, all of which are established risk factors for preeclampsia. Levels rise in mid and late second trimester, so it is a second trimester marker. Soluble endoglin again is a anti-angiogenic factor. It is a truncated version of transforming growth factor beta called endoglin, secreted by the syncytiotrophoblasts and endothelial cells of the blood vessels. It basically amplifies the vascular damage caused by SFLT. So the rise also is happening in mid to late second trimester, rises 2 to 3 months before the onset of severe early preeclampsia. Along with placental growth factor and uterine artery pulsatility index, its prediction rate is at around 77%. Another important marker is cell-free fetal DNA. So cell-free fetal DNA is detected in maternal blood circulation in normal pregnancy and has several clinical implications in diagnosis of fetal aneuploidy. Now, a more than normal increase is seen in preeclampsia, up to a 5-fold increase in preeclampsia vis-a-vis a normal pregnancy is seen before the onset of clinical symptoms. This rise is said to be a result of the accelerated placental cellular apoptosis from the hypoxic and oxidative stress in the placenta, which has not been perfused adequately. Rolnick et al. Observed increase in median total cell-free DNA at 11 to 13 weeks in women who subsequently developed early onset preeclampsia. But when he converted these values into multiples of median, they were not statistically significant. And so he concluded that this is a very poor solitary marker, but its role in combination with other markers needs to be evaluated further. Fetal hemoglobin and A1 microglobulin are other good markers of preeclampsia. Fetal hemoglobin leaks out into the maternal blood due to oxidative damage of the placental barrier, and it also is involved in the pathogenesis of preeclampsia. The ferrous heme moiety present in the fetal hemoglobin causes nitric oxide depletion, thereby causing vasoconstriction. The ferric heme moiety also releases free oxygen radicals and causes an oxidative stress, and it also causes inflammatory changes. It starts rising from around 10 to 16 weeks in the maternal blood, and the rise correlates well with the severity of preeclampsia. It can be tested by ELISA methods, and it has a good predictive value. The A1 microglobulin is a heme and radical scavenger. So basically, it tries to undo the damage which fetal hemoglobin is doing and tries to protect the tissues against the effects of fetal hemoglobin. Their concentrations in maternal serum or plasma can be used as early predictive biochemical markers. There are other biochemical markers like microalbuminuria, wherein more than 375 milligram per liter is a marker of preeclampsia, urinary calcium creatinine ratio, angiotensin 2 type 1 receptor antibodies, more of a reflection of renal causes, adiponectin, which is the adipocyte derived
I think there's some technical problem with Dr. Rekha.
Yes, ma'am. Madam,
Again?
internet connection. Yeah, ma'am. Ma'am, you can unmute and you can continue, ma'am. Rekha, ma'am, you can unmute, ma'am.
Rekha, madam, you have to unmute yourself.
Am I audible now?
Yeah, ma'am.
Oh, I'm sorry for the interruption.
Yeah, no, ma'am.
You have to share your screen again.
Yes, ma'am.
Yeah, I'm doing that. Okay. Is it visible now?
Yes, ma'am.
So urinary N-acetyl beta glucosamine also increases more in preeclampsia vis-a-vis a normal pregnancy for the same gestational age. Another marker is serum thrombomodulin antigen, which is raised in preeclampsias, and it helps to diagnose preeclampsia from other pre-gestational, other causes of gestational hypertension. So these are the various biomarker levels in a tabulated form, and we can see that most of them reduce. Only SFLT and soluble endoglins are seen to be increasing, and their mechanism of actions have been just demonstrated in this. Now this graph clearly shows various markers which have been used for prediction, but two which stand out are an albuminuria, which of course is a late marker, and Doppler changes, which are having statistical significance in the prediction. Of course, this graph does not take into account the novel biomarkers. So tests which had a lot of value initially, but are finding less and less value in today's field in diagnosis are a supine pressor test, an angiotensin challenge test, and an isometric exercise test or the clench test. They are all time consuming with a lot of interpersonal variation, and hence they are not reliable when they were studied in larger studies. Uric acid levels are actually increasing. Uric acid level is a predictor of progression of the disease, but not useful for prediction of the disease. And in fact, rising uric acid level in a preeclamptic woman indicates a bad fetal prognosis, and it actually guides you to early delivery and interventions. There were large studies which were conducted and which showed there was no correlation between a person who has thrombophilia and association with preeclampsia in pregnancy. So screening of thrombophilias per se is not advised in as a predictor for preeclampsia. APLA antibodies, yes, have strong correlation with the occurrence of preeclampsia, but screening should be limited only to patients who are at risk of APLA antibodies, cannot be applied for the general population. Now, after coming to know all these biomedical, chemical, and biophysical markers, they have been utilized by several algorithms designed by various investigators who have used risk factors, biomarkers, and mean arterial pressure, and have come out with their own algorithmic calculations. Typically, what has been used by most of them is the mean arterial pressure, uterine artery pulsatility index, a placental growth factor, and PAPPA in the first trimester. And they replace PAPPA with SFLT in the second trimester between 19 to 24 weeks. Using these tools in an algorithmic fashion, the prediction value has ranged from 75 to 92% with various investigators at a false positive rate of 10%. A very good algorithm is available at the Fetal Medical Foundation website, and which can be used by putting in all our data, and they will be able to give the risk for that gestational age. Once we identify a woman as a high risk, we can counsel her to address her modifiable risk factors like controlling her weight, controlling her pre-pregnancy weight, etc. And then she can be made aware of what symptoms to expect if the disease starts. Now, this Fetal Medical Foundation, as I told you, they have come out with a very good predictive algorithm. And how they reached it was they determined the pre-existing risk by taking into consideration all the maternal characteristics, the medical and the obstetric history. And then they calculated several biomarkers. They expressed them as multiples of median. And applying these two, they could estimate the posterior risk or the forthcoming risk in the pregnant woman. They have studied more than 60,000 pregnancies, of which 1770 turned out to have preeclampsia. And when they added one method to the other, their detection rate went from 45% for history alone, to around 75% when they added history, when they added mean arterial pressure, uterine artery pulsatility index, and any of the placental markers to history. Their percentage of detection went up to 75%. Now, having spoken about prediction, how can we prevent preeclampsia? So, since delivery is the only definitive cure of preeclampsia, any effective preventive measure could significantly impact the fetal-maternal outcome by helping us prolong the pregnancy till a good viability for the fetus. Aspirin in low doses has proved to have a preventive role in preeclampsia for a very long time. But what has been under study always has been the right dosage, when to start, when to stop, and whether it has any side effects and what is the best time to give. And I'll be going through all that in the next few slides. Now, how aspirin works, we all know. It prevents platelet aggregation. It acts as a thromboxane A2 inhibitor, and it also works as inflammation modulator. Now, when given as a single low dose, it rapidly tips the balance towards prostaglandin I2. Now, prostaglandin I2 is a vasodilator. Thromboxane A2 is a vasoconstrictor. In preeclampsias, when the placentation is abnormal, there is a natural tilt towards vasoconstrictor elements, and aspirin tries to tip that balance in favor of vasodilatation. Aspirin at 150 milligrams per day, starting from 11 to 14 weeks and given up to 36 weeks or even later in all high-risk cases identified by combined screening methods, has shown to reduce the rate of preterm preeclampsia, that is before 37 weeks, in more than 60% cases, reduction in preeclampsia before 34 weeks in more than 80% cases, and reduction in early preeclampsia, that is before 32 weeks, in nearly 90% of cases. So these figures look very suggestive of a very good role of aspirin in prevention of preeclampsia. There's a 2019 meta-analysis of 74 trials taking into consideration more than 40,000 women, which showed that there were 16 fewer deaths per 1,000 women who were treated with aspirin as opposed to women who did not receive aspirin from the early pregnancy. Now, this is the same findings in a graphical representation, wherein the best results were seen up to 90% in less than 32 weeks, around 80% in less than 34 weeks onset of preeclampsia, and before 37 weeks, at least 60% people were found to not develop preeclampsia. But here we can see that above 37 weeks, preeclampsia starting around 37 weeks, aspirin does not play a role, because here the preeclampsia is not due to placental problems, but it is because of a maternal vascular endothelial dysfunction due to pre-existing medical issues. In addition to reduction in preeclampsia, aspirin also reduces the risk of abruption by 30%, and it reduces the length in NICU by around 60%. So, role of aspirin in prevention, starting around 11 to 12 weeks, reduces the risk of placental abruption. Significant differences were seen when given before as opposed to after 12 weeks. Major causes of abruption, abruptio placentae was found to be impaired placentation, and if aspirin is given earlier to the complete placentation, that is before 16 weeks, around 11 to 12 weeks, the risk of placental abruption can be reduced. But it has been seen that if started after 16 weeks, it may actually increase the risk of abruption in an already defectively developed placenta. Now, one important aspect which I found was that taking aspirin in the night at bedtime as opposed to morning was found to have a better effect, because they say COX-1 dependent platelet activity was found to be significantly reduced upon awakening after low dose aspirin taken in the previous evening. Hence, a night dose is preferred. At doses of less than 150 milligrams, they found that there were more non-responders. Now, so we say that aspirin in dose of 150 milligrams starting at 11 to 12 weeks, stopping at around 36 weeks, given at bedtime, and works by antiplatelet aggregation, as we all know, contraindicated only in allergies and asthma, and relatively in GI bleeds and hepatic dysfunction. So aspirin turns out to be our star performer. So these are various society recommendations for aspirin recommendations. Now, calcium is said to have a role, but only in women who are on a low calcium diet and those who have other risk factors along with the low calcium diet. WHO recommends a dose of 1.5 to 2 grams per day. And there's a Cochrane study of 13 trials which says the same thing. There is no role in prevention in restricted physical activity, but they say avoid strenuous work, low salt diets, fish oils, magnesium supplementation, vitamin C and vitamin E supplementations are actually more harmful and less beneficial. Nitric oxide donors like L-arginine, in smaller studies, they have found that L-arginine works, but larger trials with lot of data does not show a statistical significance as of now. This is again a chart which shows all the preventive aspects, and what stands out is calcium and antiplatelets, which have statistical significance in prevention. So conclusions: and early detection, monitoring and supportive care improves fetal-maternal outcome. This we have known by the first trimester screening of Down syndrome, where we have used ultrasound. Please give me power. Ultrasound scanning biochemical markers for the prediction, and we have been able to predict a lot of fetal aneuploidies by doing first trimester screening. Similarly, first trimester screening can also be applied to preeclampsia. Blood pressure monitoring remains the gold standard. Uterine artery pulsatility index is a reliable indicator of preeclampsia in first as well as second trimesters. And potential first trimester markers have been pregnancy-associated plasma protein A, fetal hemoglobin, A1 microglobulin, which are visible as early as 10 weeks. Placental protein 13 has shown potential as a biomarker. Sorry for the interruption. Just 1 minute. I think my power is going. Chetan, will you connect it for me? Where is it? I'm so sorry for these interruptions. Placental protein 13 has shown potential as a biochemical marker in early onset preeclampsia when combined with uterine artery Doppler. Placental growth factor is coming up as a robust first trimester marker when combined with mean arterial pressure and uterine artery Doppler, and in a ratio along with SFLT. Now, anti-angiogenic and angiogenic factors are promising upcoming biochemical markers. A ratio of SFLT to placental growth factor in second trimester is a good marker, as it rises as early as 6 weeks before the clinical onset of the disease. In future, combining all these biomarkers into a single angiogenic marker can probably be more predictive. And angiogenic biomarkers can also help us distinguish preeclampsia from other causes of hypertension. A deranged level of these biomarkers can actually does correlate well with the severity of the disease and can be used in future for risk stratification. In the future, we may also have a specific antibody to these anti-angiogenic biomarkers, and which can change the way we treat preeclampsia today, in the sense that by use of these monoclonal antibodies, we can actually prolong pregnancy by improving her placental function. The carry-home tips are to screen modifiable risk factors in the first preconception consultation and counsel her about the same, like to lose weight or to control her blood pressure before she embarks on a pregnancy. Once she comes in the pregnancy, at the first antenatal visit, she has to be screened thoroughly on the basis of historical markers, identify her. And if she is identified as a high-risk case, then she has to be monitored very intensively. First trimester, she can be marked up for mean arterial pressure, uterine artery pulsatility, and the first trimester biomarkers of placental growth factor and placenta-associated plasma protein. Second trimester, we can do along with mean arterial pressure and uterine artery and placental growth factor and SFLT test also. The calculators are available on various sites. The Fetal Medical Foundation one, again, I say, has a very user-friendly interface. And once diagnosed to be at high risk, secondary preventive measures in the form of aspirin and calcium supplementation can be started. So with a close prenatal monitoring and early diagnosis and an intensive natal monitoring and timely interventions, we can improve fetal-maternal outcomes and also reduce the cost of therapy burden to the patient. So now that we know that most of the diseases which are seen in the later pregnancy have their origin in the early stages of pregnancy, basically the first trimester. So it is worthwhile to shift our focus to more investigations in the early part of pregnancy, so that we can take better care of the patient and invert the pyramid of health. These are my references, and thank you. Thank you very much.
Thank you very much, Dr. Rekha, for this exhaustive lecture on prediction. And as rightly pointed out, actually, I should thank you for sharing the HDP gestosis scorecard of Foxy and the different algorithms which are available for prediction. So thank you very much.
Thank you.
So shall I share my screen, Stalin?
Yes, ma'am, you can share, ma'am.
Good evening, everybody. In the next 15 minutes, we'll be looking something into how to improve the oocyte quality. So this part of my lecture is somewhat different from the earlier two lectures. First, let us look into some aspects of physiology. An oocyte, in the simplest term, is an immature egg cell. Oocytes are produced in the ovary called as gametogenesis, and the process of formation of a mature female gamete is what is called as oogenesis. The process of oogenesis starts in utero itself. So in the fetal ovaries, there is development of what we call as primordial germ cells. So they start to develop as early as 9th week of gestation, and they reach the maximum development as early as 20th week of gestational age. By this, at birth, the number of the oocytes are approximately 1 to 2 millions. There are two types of oocytes if we go into the histology and also the cytology point of view. The first one are what are called as primary oocytes. The second one are called as secondary oocytes. The primary oocytes are also termed as GV and MI. We look into in the next slides what is this GV, MI, and secondary oocytes being called as M2. If we look into the development of the oogenesis, after puberty, each primary oocyte gets surrounded by a good number of granulosa cells. Then this oocyte is called as a primary follicle along with these granulosa cells. The primary follicle then gets surrounded by even more number of granulosa cell layers and also the new theca cell layers. Now this oocyte along with these multiplied layers of granulosa cells and new theca cells, now we can term it as a secondary follicle. The secondary follicle soon transforms into a tertiary follicle or an antral follicle when there is a fluid-filled cavity within the follicle, which we call it as an antrum. At this stage, the primary oocyte now would have completed the first meiotic division. So if we look into this figure, you will now clearly understand the two types of the oocyte, that is the GV stage of oocyte and the M1 stage of the oocyte. During the first phase of the first meiotic division in the prophase 1, the nucleus takes a very, very special form. This special form is what is called as a germinal vesicle. So that is why it is called a GV stage oocyte. Slowly what happens is there is a breakdown of this germinal vesicle. This breakdown of the germinal vesicle indicates a resumption of the meiotic division and the extrusion of the first polar body into the oocyte. So then the oocyte immediately enters into the second meiotic division. So if you look into the two figures, the first is the GV stage of the oocyte and second is the M1 stage of the oocyte. And then coming to the secondary oocytes, these are the M2 at the M2 level, that is second meiotic division. If you look into the figure also, you will just understand, if you go into the what you call genetics, the mitosis, meiosis, if you remember those, we'll now understand that in the secondary oocytes, there is a second meiotic division happening. So this is in a nutshell, the whole process of oogenesis, right from in utero, ovary, at puberty and later on. Then what is more important for us is the competency of this oocyte, whether this oocyte is competent for fertilization or not. So that is the crux of the issue. It is important that oocyte quality and oocyte quantity, both are important. Alone oocyte quality will not ensure a good fertilization. Alone oocyte quantity also will not ensure fertilization. So therefore, the competency of the oocyte depends on n number of factors. If we look into the structure of the oocyte, it has good amount of cytoplasm, which contains many types of molecules to nourish the cell at in the early development. So if there is any deficiency of the molecules which are nourishing the oocyte in the cytoplasm, probably this is a defective oocyte. Similarly, the nucleus. During the primary oocyte stage of oogenesis, the nucleus is called as a germinal vesicle. So any defect in this germinal vesicle in the nucleus part of the primary oocyte also will lead to a poor quality oocyte. The next is the number of mitochondria. So the number of mitochondria also has certain influence on the quality of the oocyte. So this is because the control of the embryonic metabolism and apoptosis and various other cellular events happen in the mitochondria. So when the number of mitochondria are less, probably this is also not a good oocyte. Similarly, the number of ribosomes also has certain influence because it is responsible for the translation of the proteins within the oocyte. Also important is the zona pellucida, which is a thick transparent membrane that surrounds the oocyte. So when this zona pellucida is also not transparent, then also the oocyte is not permitting the fertilization to happen by the sperm. So having understood that there are a lot of intricate metabolisms within the oocyte, making it a poor quality. So let us now understand what determines the oocyte competence. The reorganization of the cytoplasmic organelles from mitochondria, ribosomes, etc. The synthesis and storage of the different transcripts and proteins which change the cellular metabolism of the oocyte. The nuclear maturation within the oocyte, which determines the meiotic competence of the oocyte. The translation of the proteins that should happen in the ribosomes at the mRNA level. So everything has influence on the competence of the oocyte. So when all or any of them are defective, there is an abnormal autocrine and paracrine signaling that happens within the cellular level in the oocyte. The other important factors which influence the competency of the oocyte at the developmental level are anti-Mullerian hormone. Lack of anti-Mullerian hormone could be one prominent factor for the poor oocyte competency. Similarly, the lack of MAPK or AKT signaling, so which is the pathway that will inhibit the meiotic progression of the oocyte, when this pathway is also abnormal, so the meiosis will not happen in the regular fashion. The spindle dysmorphology, which will arrest the meiotic division, also can influence the competency of the oocyte. And also the telomere shortening within the chromosomes of the oocyte also might have a poor competent oocyte coming up. And earlier I said that the mitochondria, the number of mitochondria, the function of the mitochondria also influence the competency of the oocyte. So let us see how exactly these are influencing the competency of the oocyte. The lack of anti-Mullerian hormones. There are several studies which say that cholecalciferol, that is vitamin D3, has a capacity to increase the anti-Mullerian hormone. So when there is lack of cholecalciferol, it automatically reduces the anti-Mullerian hormone and can influence the competency of the oocyte. And there are certain molecules which increase the vitamin D receptor and enhance the vitamin D3 activity at the cellular level. And one such molecule is policosanol. So this molecule increases the vitamin D3 receptors and enhance the vitamin D3 activity at any cellular level, also at the oocyte level. Zinc monohydrate is another vital nutrient that acts via increasing the vitamin D3 receptor at cellular level. And like what I've said, the lack of signaling, this lack of signaling can be modified by melatonin. So melatonin enhances the signaling pathway within the oocyte and can possibly increase the competency of the oocyte. Tryptophan, so that is a precursor of melatonin. So with addition of tryptophan, which is a very specific amino acid, it can endogenously produce melatonin and influence the pathway of signaling at the cellular level. So therefore, the quality of oocytes is very important. The quality of oocytes can be influenced in diseases like polycystic ovarian diseases. So the oocytes, if at all produced in the polycystic ovaries, are of less competence. Similarly, the stimulation protocols which are used in the ART techniques also have influence on the quality and competency of the oocytes. Endometriosis is another important factor influencing the quality of the oocyte. And another very important factor is the advancing maternal age, which has influence on the poor quality of the oocyte. Polycystic ovaries, the oocytes are less competent. This is because there is a prolonged folliculogenesis in polycystic ovaries, and there is a hyperandrogenic ambience within the Graafian follicle. So this prolonged folliculogenesis in a hyperandrogenic ambience is the root cause of poor quality oocytes being produced in a polycystic ovary. I said the stimulation protocols also influence the quality of the oocyte. And there are certain intrinsic factors that influence the oocyte quality. The follicular environment, especially in the endometriosis, affects the oocyte quality and also embryonic development. So this point was researched and then concluded in so many studies by many authors. Similarly, oocyte coming from minimal or mild endometriosis patients have decreased oocyte quality due to impaired mitochondrial structure and function. So the environment is not good, and also the mitochondrial activity is also not good in endometriosis, leading to poor oocyte quality and competence. This slide shows advanced maternal age having influence on the poor quality of the oocytes being produced. So advanced maternal age, the oocytes quality are poor, and these oocytes are less competent for fertilization. So what can be done to improve the oocyte quality in IVF and to improve the IVF outcomes? So that is the main solution for all these problems. Better stimulation protocols, pre-genetic diagnosis. The other important is to alter the signaling within the mitochondria at the mitochondrial level. So how to do all this? So there are many supplements which earlier we thought to be empirical supplements to improve the oocyte quality, but now lot of evidences are coming up saying that these supplements definitely would improve the oocyte quality, making them more competent for fertilization. So let us look into these molecules. One is polycosanol, gamma-tocotrienol, zinc sulfate monohydrate, cholecalciferol, that is vitamin D3, coenzyme Q, L-tryptophan, that is the precursor of melatonin, and dehydroepiandrosterone. So these supplements, either alone or in combination, are now not empirical supplements, but they are evidence-proved supplements to improve the oocyte quality. So let us look into the different studies which have proved that. So vitamin D as a follicular marker of the human oocyte quality and as a serum marker in vitro fertilization was well studied in number of cases. And this polycosanol acting via influencing the vitamin D3 receptor at oocyte level has been approved good supplement to increase the oocyte quality. Similarly, the gamma-tocotrienol also has various clinical studies which says that the oxidative stress within the oocytes and developing embryos can be reduced to a minimal by addition of this supplement. Zinc sulfate monohydrate, extensive studies were done in animals and in human beings, saying that they influence the competence of the oocyte and improve the quality. Similarly, vitamin D3 directly has a lot of influence in improving the IVF outcomes after ART techniques. So many evidence-based appraisal studies have happened with vitamin D3. Similarly, coenzyme Q10. Pre-treatment with coenzyme Q10 improves the ovarian response and embryo quality. I have searched on net, so many studies were proving with evidence regarding the effect of coenzyme Q10 over the oocyte quality. Then beta carotene, also improving the oocyte development by reducing the oxidative stress and increasing the maturation. Studies in vitro and in vivo both have proved similar effect. L-tryptophan as a precursor of melatonin also improved the IVF outcomes and the Doppler parameters in different IVF stimulated cycles. Dehydroepiandrosterone, which most of us are already using as a supplement, in improving the oocyte and embryo quality in IVF cycle was proved beyond doubt with evidences in number of studies. So there are so many simple ways to improve the oocyte quality. So evidences have said that these nutrients are proved to improve the oocyte quality. So therefore, if we wish to have successful pregnancy outcomes with ART procedures, these supplements can be used liberally so that the ultimate outcome would be fruitful for the couple. So this short presentation of mine on how to improve oocyte quality with some evidence base using small nutritional supplements. So thank you very much for a very patient listening. And also thank you the Shield Pharma people for involving us in this webinar. So extensively done by the important presentations by Dr. Sailaja, Dr. Rekha, and thank you very much for involving all three of us. So thank you very much.
Thank you, ma'am. Thank you very much for those wonderful presentation, ma'am. Shailaja ma'am has some emergency, so she has left, ma'am. And thank you, Rekha ma'am, for your wonderful presentation, for sharing all those guidelines and data from Foxy also. Thank you, ma'am. Ma'am, as for now, we have not received any questions in the chat box, ma'am. So let us wait for one or two.
No, the presentations were so exhaustive and elaborate. We did not expect any questions either.
Vani, your talk was very interesting in the sense
Thank
that you pointed out some very good connections like vitamin D3 and AMH connection and these new nutrients. Some of them we knew, like as you said, dehydroepiandrosterone and the other molecules, coenzyme. But certain new names you have mentioned and tryptophan melatonin link. So that really very informative. Although short, but very informative.
Thank you, ma'am. Thank you. So thank you, Stalin.
Yeah, ma'am. Thank you for your presence, ma'am. Thank you for spending your valuable time with us today, ma'am. And I request you to continue with us for more webinars in futures too, ma'am.
Okay, how many attendees were there?
Ma'am, that I cannot find now, ma'am. That IT people have to schedule it tomorrow, ma'am. I will send you the details tomorrow morning, ma'am.
If you have any recorded version, so please share it with us.
Yes, ma'am. It's available in YouTube, ma'am. We will send you the copy also.
Thank you very much, Stalin.
Sure, ma'am.
So thank you, Madam Rekha.
Yeah, same. Thank you, Vani, and thank you, Stalin.
Yeah, thank you, ma'am. Thank you, ma'am.
Have a good day. Bye.
Yeah, good. Have a good day, ma'am. Thank you.